Hi, this is Dr. Tom Rogers coming to you with a weekly podcast of the Common Sense MD. Today I have a special guest from West Palm Beach, Florida, who happened to notice some of our information that we have on our podcast out there. So it was an honor, really, that he reached out to us and really wanted to be on our podcast. That's very unusual. Usually when I get some of the super specialists, like I did last week, cardiology, I have to go to them, but he came to me, which is a real honor. So Dr. Brett Osborn, welcome into the podcast. This is on Skype, so we're going to do it that way, and hopefully someday I can get him up here to Tennessee and actually do more of these together. And maybe I can even come down to West Palm Beach. That's a much better deal than you coming to Tennessee. Although in the summer you might want to be here. It's pretty hot down there probably right now.
You are 100% correct. And thank you very, very much for having me. It's the pleasure is all mine. I am honored to be on the podcast and to again just try to get the message of health, spread the message of health as you've done for the past 7 years. You said you've been doing this, so you're way
17
ahead of the game. My God, yeah.
17
practicing
years.
for all those other years,
Yeah.
but I'm just talking about just in the digital space. So I think it's
7 years on these podcasts.
Yeah, I think it's terrific. I mean,
when
mine's
I
very,
went
very
rogue,
nascent relative to yours.
When I went rogue 17 years ago and opened my own practice, everybody thought I was nuts, as we talked about before, but it's actually developed into a kind of a new way of practicing. I tell people often that I don't believe so much in myself as I do in what I'm trying to do. And what I'm trying to do is change the way medicine's practiced. I mean, as you know, we're in a bad place with our country. I mean, we spend so much money on medicine, yet we're 33 in the mortality rates in developed countries. I mean, we've got a pitiful record on keeping people healthy. And in my opinion, you can see what you say, but the two major problems we have in this country, health-wise, are obesity and then I think drug use. I think those are the top two that I've come up with. But so I have a fight against obesity. I do that all the time. We talk about insulin resistance. A lot of people just don't understand obesity a lot. And you were so kind, your son Ellis was so kind to send me your book that you wrote, and I was just blown away by how much we think alike, and I was definitely jealous of your workout routines. I mean, you're a fitness nut, obviously, and here you are, a busy neurosurgeon still practicing, but is into longevity medicine and kind of come at it with a common sense approach, kind of like what I do. But we're going to talk about a few things today, and I hope I don't take up a lot of your time, but how did you realize that you wanted to get into this type of practice when you're so busy operating on trauma brains and heads and things?
Right. So that's a great question. And, to tell you the truth, Tom, I've been into this stuff from a sort of a personal standpoint for ever since I was maybe 9 or 10 years old. So I grew up in a holistic family. My dad is a practicing chiropractor of 55 years. He's going to be 80 in February, still practicing. So it was very, very, we had a holistic approach to health. I started training with my dad when I was either 9 or 10. And I remember going into the sort of the back room of the house, and we had what was called a universal machine, which was sort of a spin-off. So this was in the late 70s, just sort of a spin-off of Arthur Jones' Nautilus machines, right? So these universal selectorized machines, these pin-based machines. And I started getting into it at that point. Incidentally, in the facility that we have here in the office, to pay sort of homage to Arthur Jones, the late Arthur Jones, the facility is lined only with Nautilus equipment, despite the fact that I'm no longer a high intensity trainer. And that's another podcast potentially. I'm more of a power lifter, as you know, along the lines of what's in the book there. But I still, because I trained that way for so many years, it's sort of close to my, that's another thing that's very, very close to my heart, HIIT style training, not the HIIT that we see nowadays, but the true HIIT as Arthur Jones had described it. I'm sure you're very, very familiar. But getting back to the question, from the time I was just, let's say 9 or 10, I was always very, very, very into how am I going to make, my mind and my body perform optimally. So despite the fact, and that continued with me. So despite the fact that I was going into, I'll call it reactive, or we'll call it reactive medicine, mainstream medicine, where we find a disease or a disease process or a syndrome, and then we treat it reactively, retrospectively. It sort of it was, this was sort of a it was contrary to almost my beliefs, to do just that. And I always had it in the back of my mind that something was wrong. So in residency, when we started treating predominantly spine patients, because the majority of neurosurgery is spine, as you know, and that's another discussion, but even brain tumors, I started saying to myself, this is really just not right. We should be treating these folks before they develop problems, before they develop back pain, before they develop neck pain, before they develop some sort of ridiculous symptomatology, which, as you know, it's all the same, and it all has its roots in arthritis. We should be preventing those diseases or those syndromes, the ridiculous syndromes, the myelopathies, by teaching people how to maintain their low back health, by maintaining the strength, of their torso, their erector muscles, their hamstrings, their glutes. That's going to thwart the development of all of these diseases. And then it was sort of this self-propagating cycle, where you start looking at other disease states and saying, wait a minute, I wonder if things like type 2 diabetes can be prevented. 100% it can be prevented. We both know. I wonder if people could stay lean lifelong. Do we have to be obese like 70 or categorically overweight like 70 or 75% of the the American population? The answer is no. And when you start looking at it that way, you start saying, well, wait a minute, obesity, diabetes, these are all sort of gateways diseases to all of these other diseases, including arthritis, cancer, heart attack, stroke, Alzheimer's disease. You can call them what you want. It's all about just geography. So that's sort of the genesis. And then when I got into my own practice, again, it was sort of ribbing me. And now what I've done is I said, you know what? I'm not going to treat those diseases anymore reactively, like arthritis of the spine. We'll just call it generically. I'm going to try to prevent people from going to the operating room, and I'm just going to deal exclusively with the folks who are critically injured in car accidents, which is it's not really a preventable problem. It is to a degree, because there are always serial errors in judgment that end up, somebody ends up in the trauma bay. So that's that's sort of the transition that my practice has undergone. It's always been in the back of my mind, but now it's just sort of manifested itself, like, akin to what you've done up there.
I love your preventative approach, and certainly that's what I've tried to do over the years. I really think type 2 diabetes is also not only preventable, it's reversible.
100%.
I liked reading your book, and I also loved your interactions. I went and looked on one of your YouTube videos with one of the TRT guys. I forget what his name was.
My friend James. Great.
Yeah. That was a great little vignette of testosterone replacement, which I'm, of course, a huge fan of.
Oh, yeah.
Probably 80% of my practice, Brett, is done with hormone replacement, and the other 30-40% is weight loss and metabolism, metabolic syndrome, and it all kind of goes together. The root cause is inflammation, as you know, and there's certain things that you can do, but like you said in your book that I was so impressed with,
I appreciate it.
You really can't cheat on these things. I mean, you have, just like the things you emphasize with your workout, there's some basic things that will never go away, like the squat and the deadlift, the pull-up, the bench press. I do my bench press now with dumbbells, but I mean, there's certain core movements that that we need to stay strong. And in my opinion, I got in my Q&A the other night, I got a great question, and it was, Dr. Rogers, considering mTOR and AMPK, isn't it better to kind of not overstimulate mTOR and just, as you age, just kind of let your body end up like a frail little old lady? I said, no, No, you got the opposite. We need to build muscle, which burns fat. Bone health depends on muscle health. So as you get older, you have to build muscle because you're losing muscle every year. And really, as far as hormone replacement goes, once you get into menopause or andropause, like I'm in, I mean, you need testosterone. I mean, you're playing a losing game as it goes down.
Yeah, 100%. I mean, there's no question. And we know that when an individual becomes sarcopenic, and this is interesting, and I'm sure you've read, similarly, that when you start losing muscle, okay, and this is just going to be very, very blunt, you start getting stupid. Okay, so brain health declines in parallel to our becoming sarcopenic. In addition, as you know, when you become sarcopenic, there is a linear relationship between sarcopenia, okay, brain health, okay, but also what's the most common cause of head injury? Most common cause of head injury, particularly in those above the age of 50. And again, this is the space that I live in.
Falls, right?
You got it.
Yeah.
You got it. So you cannot lose muscle. It is your most important asset, as far as I'm concerned. It is where your resilience lives. It is where your resistance to disease lies. So I'm going to give you another example. This is real world. You take somebody, and we'll just say they're 50. Okay, they're 50 years old, and you have an individual who, just let's say, is not hormonally optimized and poorly exercised, and we'll even call them, they may be mildly overweight. Fine. Then you take the other individual, okay, who's got some stock to them, same head injury, who's walking out of the hospital. There is no question, okay, that person that's got the muscles on their body, that's got those protein depots, right? Yeah. We pull protein out of our muscles. They allow us to form antibodies. They allow us to mount an immune response. They allow us to stave off disease, stave off ventilator-associated pneumonia, because a lot of these people are intubated. You know that, right? Those are the people that are going to live. The sarcopenic folks, they don't. Okay, so your resilience is in your muscularity, and you know the data. Okay, I put a citation in the book, British Medical Journal, 2008. 8,762, it was men, but you can be assured that it's women as well. All-cause mortality, okay, including cancer, and independent of cardiovascular fitness. Independent of cardiovascular fitness is directly related to your strength. This is well established. So when you come to the clinic here, and I'm sure you do something similarly there, or maybe you even do something even in a more robust manner. Quite frankly, I'm embarrassed that I only do this, but it's sort of a function of, it's a time thing. It's a, how do we do this and guarantee an individual is not going to get hurt when we're not sure about their level of fitness or their flexibility, et cetera, their mobility, et cetera, et cetera. We know for a fact that an individual's grip strength is linearly related to their overall body and their body strength. Okay.
Most important measure of strength is grip strength.
Correct. Okay. So then you explain to the patient, listen, if you're weak here, you're probably just, and not in a demeaning manner, you're probably weak throughout, and therefore you're more likely to die than somebody that is in the next quartile, if you will, strength-wise from the. So I don't know if you do dynamometric testing, but we do it here. I should be doing other things like, seeing how much somebody can leg press, like emulate what was done in that 2008. But maybe it's not in that 2008 British Medical Journal article. But maybe it's not necessary. Maybe grip strength is just enough. And we check it serially. We want to make sure that people are stronger. How do you get stronger? Squat, deadlift, bench press, overhead press, and a chin pull. That's how you're going to get your grip stronger. That's how your entire body is going to get stronger. That's how you're going to live longer.
I tell people just to hang from your chin up bar.
Sure.
And see how long you can hang there. It's surprising how short it is on most people.
That's correct.
I work on my hanging time. I do that routinely.
And you know that there's data on that, on hanging time, and longevity. And also, in getting back to the sarcopenia, the falling, that there are data, and I can't remember where I've seen it, but it's definitive. I've read it. Standing on one foot. and you
Yep.
stand on
Yep.
one foot for 30
Yep.
seconds. I
Yep.
forget where that we,
Yep.
the citation, but
Yep.
it exists,
Yep.
right?
Yep.
And you think, well, wait a minute. Well, why does that mean anything? You could stand on one foot for you can, you can't. It means a lot. Okay,
Proprioception, balance, prevention of
a hundred
falls.
percent, a hundred
You
percent.
know what I tell my patients is, and this is the main test I do. I'll have them get in the floor, and I say, I want you to get up without using your arms. Can you
Yeah.
do that?
Mm-hmm.
And most people can't.
Mm-hmm.
Even
That's
most
right.
people you think may be able to. Some people
Right.
can't even get up with one arm.
Right.
But
Like a
you should be
Turkish
able to
get
get
up
up
type of thing.
without
Yeah.
anything, just your
Yeah.
legs.
Yeah. Oh, I get it. Same exact thing. So that's your barometer. Maybe we need to start doing that down here. No,
Yeah.
I think that's clever. I can see how that could be challenging for a lot of
And
people.
you can teach them how to do it too. I mean,
Right.
not only there's a little bit of technique to it once you reach a certain age, but the other thing I was thinking about when you were talking about muscular fitness and mortality wise, and you're right. I mean, look at what the patients that died of COVID. I mean, most of them were obese and low vitamin D as well, but you've ever heard of dinosaur syndrome? It's where a dinosaur has a very small brain but a huge body. Same thing with obesity. If you're obese, your brain is not working as good.
That is very interesting. I'm going to steal that from you. I'm going to steal that from you. That's great, actually.
Yeah, you
That
have
is
dinosaur
great.
syndrome. You've got an obese body and a very small brain.
Right,
We
right,
want to
right.
reverse that for you. But
Right, right.
I love this stuff that we're talking about. So I'm a big believer in testosterone replacement, of course, for male and females. It's amazing how many, in this area of Tennessee, I'm probably known as the expert in hormone replacement. There's no doubt. I probably replace more testosterone than anybody in our whole state. I'll almost
Good for you.
guarantee it.
Right.
But and women need it just as bad as men do.
100%.
Women are mischaracterized. There's a lot of misconceptions about hormones in women. Of course, these bioidentical hormones we use do not cause breast cancer. Testosterone does not cause prostate cancer. There's so many misconceptions about it, even among most doctors. Most doctors don't know it. Even your gynecologists don't know hormones for women like they should. They go, this woman's on testosterone. What? Of course women need testosterone.
I share your sentiments. We have it happen here all the time. All the time. It is constant. The emails are flooded, I'm sure, like yours, about I'm concerned about this cancer. I'm concerned about this cancer. I had a woman in here a week ago who was concerned about being on testosterone because she had a lung mass removed years ago, and she was nervous that it was going to cause the tumor to recur. And I said, no. There is no oncogenic, potential of these bioidentical hormones. Otherwise, as you know, and you probably have told patients the exact same thing. Everybody when they're 21 years old would have tumors coming out of their heads. It'd be all over the place, right? When your hormones are all
How
the
many
way up
20-year-olds do you see with prostate cancer?
Right.
But there's a lot of misconception. Like typically,
Right.
I'll get somebody that goes to see their cardiologist, and the cardiologist says, "You better get off that testosterone. It's going to cause blood clot." It doesn't cause blood clot. So there's a lot of misconceptions about that. And
exact same thing we have going on here, and I'm sure you hear that all the time.
And you have to know the nuances like you do in speaking with your colleague about, you have to watch estrogen levels. You have to know about DHT. You have to know that it can pop your crit up a little, you have to know what you're doing when you do replacement of hormones. Same thing with females. The estrogen progesterone ratio is so important, the DHEA. But and here, I don't know about you, but I do a lot of peptide therapy with people. I don't know if you're into that yet, but that's a whole new world that's amazing.
Right. So if you had a lot of successes, because I've obviously fiddled with it for years, and maybe I haven't tried the right ones. In my personal experience, I believe the one that I sort of have a lot of faith and confidence in, the one that I recommend to my patients, because a lot of us have joint pains, particularly the ones who lift heavy, is BPC 157. The other peptides, I've not been much enamored by, but my experience is probably not nearly as vast as yours. I probably have tried myself a half a dozen of them over the years, but there are a litany of these
There's a
as you go.
ton of them. I
Right.
agree. BPC 157, which is the only one I'll even use orally.
Yep.
It works orally as well, especially if you have
Sure.
gut problems. But
Sure.
the one I take, and here's the thing about peptides that I've found out
I'm
that
writing this down, by the way.
I
I am.
like CJC 1295 with
Yep.
ipamorelin. I take that personally. But here's the thing about the peptides that I've found. I'm like you. If you just take it for a month or so, you're not going to notice anything. You have to stay on them for 2 or 3 months, and then it's subtle. I mean, it's not like popping somebody on testosterone.
Hmm.
You have to do that. You have to wait. And there's a lot of hokey peptides out there too.
I
I mean, you
know.
can get them over the
I
counter or
know.
order them off the internet.
I know.
I tend to use the legitimate compounding pharmacies. There's a
Mhm.
couple of them
Sure.
that I actually interacted a lot with down in Orlando, down at our last A4M conference. But
Mhm.
so that's my favorite. BPC 157 is another one. Alpha thymosin's a pretty good one. Um, if people can't afford the CJC 1295 with ipamorelin, Samorelin is the
Mhm.
next best choice there. The idea is to raise your growth hormone levels.
Right.
I've played around with growth hormone a little bit in
Hmm.
the past. Number one, in Tennessee, it's not legal. We can't legally prescribe it in this state. I
Yeah.
think
Same
in
thing here.
Florida,
We have
I'm not
problems.
sure. But anyway, I mean, that's a dramatic growth hormone itself is a dramatic hormone to use for repair and for leanness. It's kind of a great complement to testosterone, which is an anabolic steroid. Of course, growth hormone, which you're trying to stimulate yourself with ipamorelin, samorelin, and those things.
Sure.
And you're not going to see your IGF move much when you do that. You're
I
just
have
not going
not.
to see it move
I have
much.
not. Yeah. I have not.
But and again, I'm not sure how much you want to move IGF anyway, but
Sure.
it's kind of confusing on that matter. But I like, there's nothing that's going to replace, like you said in your book, and this is absolutely true. There's nothing in the world that's going to replace exercise, including weightlifting. That's number one of any health plan. Number two is what you put in your mouth. Number three is probably how you sleep. Number four is how you're doing with stress. Number five is hormone optimization.
Sure.
And not just testosterone, estradiol, growth hormone, but we're talking about cortisol. We're talking about insulin. We're talking about thyroid. We're talking about vitamin D, which is a hormone.
Sure.
So all these play together, and I do some pretty extensive blood work in my offices where I check a lot of things, including vitamin levels, methylation, mutations. I look at, talking about brain, I look at the ApoE genotype.
Mhm.
I want to know if somebody's dealing with a 4-4 pattern.
Sure.
I saw two this week with a 2-2 pattern.
Did
I
you?
saw two patients that had a
Mhm.
2-2.
Yeah.
They hit the double lottery. I
Yeah.
just never see that. But
Yep. Yep.
any event, growth hormone's pretty amazing. Years ago, I tried it myself, and at the time, I was racing bicycles and road bikes, and that's the best I've ever felt. But you got to be careful with growth hormone because it definitely popped my sugars up,
Yeah.
and it's just kind of semi-dangerous. You have to know what you're doing. It's never been shown to cause a tumor, but say you had an occult tumor hiding somewhere, could it make it grow faster? Maybe it could, but I've seen it give people carpal tunnel. But
Oh, yeah.
as far as short-term, do you find that in the guys you see, and a lot of them use growth hormone under the table and things like that?
Yep. And we try to discourage it, here in the clinic. Again, it's very, 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 very tightly regulated down here in Florida. But there are guys, obviously, and gals that are, that are fiddling with it. And I always am the first person to say, listen, you're a big boy, or you're a grown woman. You can do what you like, okay, outside of here. You're not getting it from me, but I will keep you healthy despite or in spite of your habits. Here are the things that you need to watch for, as you had mentioned. We have to watch, for patients developing any acromegalic features, carpal tunnel, I find that people come in, they're hypertensive, their sugars are through the roof, they're insulin resistant, despite the fact that a lot of them are very, very lean. And as you know, a lot of them, particularly the folks who are, really abusing it, they have a huge gut.
Yeah.
Okay,
Yeah.
you know this. You see the GH gut like the bodybuilders get.
Yeah.
It is very, very, very classic. I have a patient here he's used it for so many years. By the time he got to me, which was about almost 10 years ago now, he was floridly acromegalic. And I said to him, this needs to be shut all the way down. And if you're going to do it, which he continues to do, I just say, give yourself X and keep your IGF-1 level right at that sort of that mid to sort of third quartile, no higher. Because as you know, driving your IGF-1 levels through the roof, which we used to thought was good, is actually no bueno. So because it does, I always tell people, look, all of these diseases that kill us, so we'll just call it heart attack and stroke, they're growth diseaes. What are you growing? Well, you're growing plaques in your arteries, right? You're growing Alzheimer's plaques in your brain. You don't want to be driving. This is, sort of what you were getting to about 15 minutes ago. The IGF-1 pathway, the growth hormone, the insulin IGF-1 pathway, mTOR's down there, downstream, right? You want to drive it, but there needs to be some sort of checkpoint. Otherwise, all these bodybuilders wouldn't be having MIs and strokes, and they are. We know that they are. So too much growth is bad, whether or not it's something that is oncogenic. If you're giving yourself too much, we don't know. Okay, as far as growth hormone is concerned, I would say if you're going to use it, you want to use a unit a night, Monday, Wednesday, and Friday to help you sleep and recover. Fine. When you start going past that, I'm not an advocate of that, and I think it's a very, very bad idea. Sort of dovetailing on what I was just saying. Ultimately, what I think is going to end up being borne out with regard to let's call it the insulin IGF-1 pathway, mTOR's down there, as you know. I think what's going to end up happening is that sort of like what we do in powerlifting, which is a periodized sort of scheme where we may go 6 weeks and it's a sort of a power phase where we're trying to augment power. Then what we do is we say, enough. You may take a full week off, and then you do a hypertrophy phase. So what I think is ultimately going to happen is, or we're going to evolve to this, is that we're going to push, and I'm just going to use a month because it's easy for everybody to understand. We're going to push the growth for just, let's say, 3 weeks. And then that 1 week, okay, the fourth week of the month, right, we're going to pull everything back. So if you're going to use growth hormone, okay, you're going to use it, right? And you're going to use it for 3 weeks, okay? And it may be 6 weeks or maybe 12 weeks, who knows, okay? We need more data, okay? But then you're going to stop and you're going to clean the body. So that would be the time where you take the 1 week where you do your fast, your 2 or 3 day fast. You take your metformin, you take your rapamycin, and you clean the body, because there's byproduct of growth, right? You're growing, right? But you're also, not only you're growing your muscle, which is very, very important, but you're also growing potentially a plaque somewhere in an artery, whether it's a carotid, whether it's a coronary, whether it's a femoral artery, and you may be growing plaques in your brain. So I think ultimately things are going to evolve in that manner. And I know you've talked about prolifically about rapamycin and things like that. I do take it myself.
I love rapamycin.
Yeah, and I think that it has its place and its role. Does it temper, like metformin, muscle growth? And is that problematic for me? Because again, I'm a competitive power lifter. It may be problematic, for me. And I can tell you that when I'm taking my metformin, although I continue to take it daily, unless I'm prepping for a meet, okay, in which case I'll back off a little bit for 6 to 10 weeks or so, 6 to 12 weeks, I'll back off a little bit on it. When I get back on, my strength goes down.
Yeah,
there's no question.
Interesting. Yeah, there's definitely a correlation with that. A couple of things I was thinking about when you were talking was that, the the real muscular, gym rats that take their own stuff, they don't come to me. They know I'm not going to give them the
Right.
doses of tea that they want. So now I do, occasionally they'll come for blood work, and I'll kind of give them a little advice. I'll check their estrogen levels or crits. A lot of them don't donate blood like they should. But
Sure.
anyway, the other thing I was thinking about with the peptides is the peptides take a while to work. I think they're definitely safer than growth hormone, definitely less controversial and affordable, but you have to take them, you have to give it time, and you have to take it on an empty stomach at night about an hour before you go to bed
Hmm.
for 5 nights a week, or it really won't work very well.
Hmm.
But I agree with you. This whole thing about mTOR is very important because, and that's how rapamycin works. It inhibits mTOR. When you're young, you want the growth phase. When you get a little older, you need repair phase. You need to clear
Sure.
out those senescent
Sure.
cells. And certainly that's what rapamycin kind of mimics fasting. Fasting's a great way to, to inhibit mTOR to where you can repair. But it's that growth repair cycle that, especially as we get older, that we need to look at. But my battle with my patients is getting rid of belly fat. I wish I could do a complete DEXA scan on all my patients. Do you do that on yours?
So the answer to your question is no, and I assume you're talking about just from the standpoint of not bone mineral
No,
density, but I assume
muscle.
yeah, just
Yeah.
yeah. So what we do, and I don't know what you use up there, but undoubtedly you have some sort of barometer or tool up there. Is we use an in-body scale, and our in-body scale is spectacular. I mean, we've been using it now
Oh,
for
wow.
I don't know, probably about 10 years, and it is very, 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 very. Um, the data is very, very reproducible, and I'm not talking about our scale to our scale from year to year, because it
Yep.
is okay.
Yep.
And
Yep.
you can see, I mean, people trend. There's no aberrant numbers. I've never seen that, not once, of thousands of of scale readings. um, but if you have an in-body scale in Florida, and we have an in-body scale by you, okay, um, you know I can say, Tom, I got this guy down here. He's going to be vacationing. Can you have a look at him? He's got some sort of issue. If you put him on your in-body scale, I'm telling you, you will see that those numbers are very, 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 very similar. So I'm not a spokesperson for InBody. I have no stock in the company. I have nothing to do with them, but I think that their scale is spectacular. Plus, it's really great because there's an app which we use. You download the app and you can actually track your progress. So it gives you skeletal muscle mass, lean body mass, body fat, visceral fat, how much weight the scale believes you should use, which, by the way, we do use that. And that is something that is also unbelievably accurate. It has some sort of normative values that are built in, I guess, from sampling over the years,
Mm-hmm.
hundreds of thousands of patients. And when you look at it and you subtract off, as an example, it'll say this guy needs to lose 30 pounds. If you go back and you look at their just their weight, forget about their lean body mass, just their weight. So say they're 230 and says you need to lose 30. Well, if you're going to put the guy in testosterone and you say, you probably gain about 5 pounds of muscle in a year, 7 pounds of muscle in a year if you train, and you sort of just do the quick calculation and you say, when were you at your best? They'll go, yeah, I was really, really good, somewhere between 205 and 210. You knock the 30 pounds off, you add the muscle, and almost 100% of the time it's spot on. It's uncanny how good the scale is.
I
And
have got to get one of those. I
so
don't.
what do you use up there, Tom?
We use a DEXA scan that we refer to. So,
Hmm.
the,
So you
but
refer that
I
out.
refer that out. I thought about buying one. They're about $130,000. I just haven't gotten the nerve to purchase
No,
that yet.
no. In body,
Um, yeah,
you will be enamored by this machine, and it'll
yeah,
cost you a tenth of that.
that is a done deal. I can promise
Yes,
you, I will get one.
you must. So we're doing a powerlifting competition, like I said, in about 10 days, 8 days actually, and we play this little game, as you could probably imagine, where Ellis competes in the 148, so he walks
Yeah,
around typically around 160. So we
yeah,
play the game with the water.
yeah,
Basically, 2 nights before we shut off aldosterone. How do
yeah,
you do that? You drink like 2 gallons, 3 gallons a day. You shut it off at the last minute, like 12 hours before, and then you just pee out all your water. And then the
yeah,
next thing you know,
yeah.
you're 10 pounds lighter and you get into the weight class, right? So I'm going to get him, and I'm going to do the same thing myself, because I'm a little heavy now. I'm about 190, and I compete in the 183 kilos, so it's about 182. Um, And this is the first time I'm actually going to get on the InBody scale, sort of the before and the after, and watch, because it
Oh, that
measures total body water and extracellular water as
I've
well.
got to have that. How does it compare with the bod pod? Have you seen something called a bod
I,
pod?
I don't have any personal experience with it. I've seen the data output, and it's a very, very similar sort of thing. Yes, it gives you your BMR.
Yeah.
And we do another thing here where we have two sort of acquisition points as far as BMR is concerned. What we do is we use the bioimpedance scale, which is, the InBody, and we also use a respiratory quotient machine, a gas exchange machine, so we can actually, and that's very informative, and I would recommend that you get one.
Do they give you a VO2 max or?
It does. Okay. But we've used it for that, for people that want to get their VO2 max. But what we do, and it's very, very informative from a patient standpoint, because what we can do is we can show them, well, here's your resting energy expenditure, whatever you want to call it, BMR, right? But what's more important is that we say, you see what's going on here when you're 40 pounds overweight? You see what you're predominantly using to make ATP? Well, when they come in and they're 85% of their ATP is from carbohydrates and 15% is from fat, we have a problem. But that resonates with people. So it's a good piece of machinery for you to show to your patients, hey, look, you're getting your ATP from Skittles. You can't do that. You need to be getting your ATP from either your waistline or from the fat that you're eating. In other words, whether it's olive oil or nuts or fish or avocado, whatever it is, right? You know this. So
I'm a huge believer in a high fat, low carb, moderate, actually higher protein guy. I don't think most adults get enough protein, and I don't think you have to worry about shutting your kidneys down. Do you? In the average person? I mean, you hear that people get scared of that, and you're going, you're not getting enough protein for sure. You're not going to shut your kidneys down.
Listen. Talking about the common sense doctor, that's you, right? Okay, so I'm common sense. I'm just going to follow when you're, right along. I'm common sense doctor number 2, or junior common sense doctor. It's the exact same thing. You know what I tell people, and you'll appreciate this. Listen, just eat like Jack LaLanne.
Yeah,
that's it. Okay, which is, you're going to have low glycemic index carbohydrates. Yeah, he was into some fruits and things like that, but low glycemic index carbohydrates, about 50% of your calories from fat. Okay. And backfill to your BMR in protein. So what we do, Tom, is we put people on the machines, okay, the various machines. We get their BMR, their average BMR from the two machines, just let's say 50% of their calories is from fat. So say as an example, your BMR is 2,000, 50%, so 1,000 calories, okay, or 110 grams, okay, is going to be from fat. I typically will start people, unless they're enormous, and so that we don't put them in withdrawal, we start them a little bit higher on the carbohydrates, not lower, because otherwise you're getting phone calls because they're basically, they have no energy because they're so used to getting their energy from Skittles. So the most people who need to lose 20, 30, 40 pounds, 75 grams of low glycemic index carbohydrates, less than 40, okay, is our cutoff here. Not 50, not 55, less than 40. So we calculate that. So we may just, let's say it's 75. So that'll be 300 calories. So now you're up to 1,300. And then we backfill, the other calories with protein. And that's it. So, we start out with the fat. 50% of your calories are from fat. Then we're either 75 or 100 grams of carbohydrates, low glycemic index carbohydrates only. And then we backfill the remainder in protein. So it's very, very easy for us to come up with a macronutrient-based protocol for basically everyone that is science-backed, or data-backed, because we're pulling it right off of their BMR. And I set everybody at their resting metabolic rate. So the scale says you're 2,000, it's 2,000. I'm not going to say, oh, we need to build muscle. No, because most people overeat. Okay. Most people overeat, as you know. Try to get to 2,000, right? We get their hormones optimized. We get them exercising. They create a little bit of a caloric deficit by virtue of the exercise. And there you go. They're losing body fat, and they're either maintaining, or, as you know, most of them end up putting on muscle just by virtue of
a lot of them in ketosis when you measure it?
No, none of them. So if it's a modified ketogenic protocol, if you're going to characterize it as something, if you were to check their blood ketone levels, you're talking about 0.2, 0.3 millimolars. Why? Because we're giving them too much protein. And we don't flood them with protein. As I said in the book, for people that are really, really weight training, okay, aggressively, just a gram per pound. Okay. The rest of the folks who are not, I don't think you need, and the literature nowadays is more in support of this to maintain muscle, even to get, to amass a little bit of muscle. Okay. Not massive amounts of muscle. We need to be in significant caloric surplus and
Yep.
eating a lot of protein because you
Right.
end up putting a lot of fat on, as you know.
Right.
0.75, 0.8 grams per pound. So a guy like me,
Okay.
190, I don't
Mhm.
know. I probably eat 150 grams of protein a day. And you know what? I'm fine.
Yeah, that sounds about right. Yeah,
Yeah.
I
What do
have
you
a
do?
hard time. People just really don't. They don't like staying in ketosis. They
No,
just
no,
can't stand it. Nobody can do it.
no.
Um,
I don't
I'm
use it.
kind of the same way. I'm not a big. I'm like. I'm now about 6 feet. I was about 6'2". As I've gotten older, I'm shorter.
I'm the same
But
way. I'm a lot shorter than you, but yeah.
but I weigh 165 pounds, which is
Mhm.
my high school weight. I've never varied within 3 or 4 pounds my whole life.
Is that right?
I'm just, yeah, I mean, some of it may be genetics, but I'm active. I'm type A. I'm very active, I guess. But I just have never, knock on wood, had a weight problem. I'm a hard gainer. I guess you classify me as a hard gainer.
Sure, sure, sure. But
'Cause I'm
you, but
not
you,
nearly as muscular as you are.
well, I also noted before, that you said you were a competitive cyclist,
Yeah,
and always, this is one of
yeah,
my sort of adages, if you will, or aphorisms.
yeah,
Sport chooses you. You don't choose a sport.
yeah. That's exactly
It's
right.
100% the truth. I mean,
That's exactly right.
I'm 5'7", on a good day. Okay. You're a lot taller, right? More of the hard gainer, right? So you're going to
Yeah, yeah,
gravitate towards the endurance sports. It's the
yeah,
way we're
yeah.
wired.
That's
Me,
ex-
if I go and, try to pedal, like you pedal a bike for 35 miles, forget it. I'll be dead after the first five. It's it's just not in the cards for me. Can you train it up? Of course. And
yeah,
for you
yeah,
to gain muscle, and whoever else is listening, just like for me to get on a bike, and to be able to do that, you have to push the needle very, very hard. So I would have to be
yeah,
out there grinding and grinding
yeah,
and
yeah,
grinding. And then I would ultimately, if I stopped, I would gravitate back to sort of my normal sort of mesomorphic body type. But
yeah,
for you, and for people that are hard gainers out there, the way you would gain weight if you wanted to do it, it's going to be a lot of aggressive heavyweight training, which is good anyway. But
yeah.
also, you're going to have to eat in significant caloric surplus,
Exactly right.
significant.
Ex-
And the problem with doing that, as you know, is that you're going to end up gaining body fat that probably you don't want.
Yeah, yeah. A lot of it depends on your tolerances on your stomach as well.
Absolutely,
I do a lot of work with gut
100%.
health, and I don't think my gut could take all that food. So
Yes.
I'm kind of happy kind of where I am. I'm not as shredded as you are, but I'm pretty lean. I
Right.
think my body fat usually runs around
I was
10%,
going to say you're looking
maybe.
here somewhere around 10% or so. Yeah,
Yeah,
I
somewhere
mean,
like
that's
that.
great. Yeah,
Yeah,
I'm not that lean. I usually run 12, 13, depending upon where I am. In sort of, if I'm fiddling around with the powerlifting competitions, I'm a little bit bulkier because I'm
yeah,
trying to eat in
yeah,
surplus prior
yeah.
to, as you know, just to get the strength up. So let me ask you a question, if I may. Do you think that there's any benefit, and what are you doing, benefit to measuring, and what are you doing with regard to, just let's say, your microbiome testing, aside from
Oh,
putting
yeah,
somebody on a probiotic?
yeah,
So what are you
yeah.
doing, and
Okay,
have you found that that has helped?
I've got some great. We looked into gut health a lot because we deal with a lot of autoimmune diseases. And
Hmm.
if I ever see somebody with an autoimmune disease, I immediately ask them, "How's your gut work?" 99% of the time, terrible. So
Hmm.
a lot of this stuff originates in the gut.
Sure.
So I do a thing called a GI map, which is a extensive stool test. GI
Uh-huh.
map.
Uh-huh.
It's
GI map. Yeah.
it's an amazing test, and um, just tells us a whole lot. I think, as a matter of fact, COVID really tore a lot of people's guts up. We see a lot of leaky gut. The best probiotic and gut pill I've ever seen is something called Digest Shield. Write
Hmm.
that down because
Hmm.
it's the
I got it.
best. I treat so much IBS and
Hmm.
so many gut problems. What that one product has, which is actually developed in Tennessee, it has prebiotics, food for the
Mhm.
probiotics. It has
Yep.
probiotics in the right amounts. You don't need 80 billion. You just need the right amounts of them and the right organisms.
Mhm.
So it has digestive enzymes to
Uh-huh.
help you break down, especially fats. Some people
Uh-huh.
can't break their fats down.
Yep.
It has lactase to
Yep.
block down dairy. It
Yep.
has the magic ingredient in this thing's called chitosan. And what it does, it blocks down glutens and lectins.
That's interesting.
So you've got 5 in 1. Check that product out. It's the best all-around gut pill I've ever seen, because otherwise you're going to be taking a lot of different ones. So
Yeah.
something I've done in my practice is I actually formulate my own vitamins. I didn't formulate this one. I use this one all the time. But I make my own longevity vitamin. I make my own energy vitamin, which has CoQ10, PQQ, and taurine in it. I
Interesting.
work with a company out of Portland, Oregon called Freedom to Formulate. And I make my own combination. You should see my multi. I mean, it is loaded. It's got 5000D with MK7. It's got liposomal C. It's got gamma E. It's got boron, zinc, all the methylated B vitamins. It's got, it's got everything you need besides magnesium, which you take at night, which I've got my own form of that too. I have the threonate, malate, and
Yep.
glycinate.
Yep.
What else? I have a bunch of them that I formulate, so you don't have to take all these different pills, and they're cheaper. I have them making, and they're pure. They don't have any additives to them. Like a lot of the good vitamin companies are putting maltodextrin in their vitamins and
Yep.
stuff as fillers you don't really want in there. So
Yes.
you can make your own vitamins.
And the name of that company, one more time, I'm sorry?
Freedom to Formulate.
Freedom to Formulate.
I'll put you in touch with the guy that I work with.
Great.
But it's really turned out great for me.
Thank you. That would be
But
great.
you can make your own. You can have your own, Dr. Osborn's vitamins.
Right.
People trust you, and I try not to be a vitamin salesman. I'm not, but I have come up with some good stuff, and I'm not embarrassed to promote it to my patients if they want it. I say, look, I'm not. You can try to get these different ones if you want. You can get a combo right here that's going to have not only your CoQ10, but it's going to have PQQ and taurine in there
Sure.
for cheaper than you're going to buy CoQ10 for over the counter. But
Sure.
So but I'll put you in touch with that guy.
Oh, that would be.
And also the GI map people. They're real easy to obtain. It's kind of an onerous test to kind of interpret. If you're not into the gut health, I've got one of my mid-levels. Really, that's what she does is gut health. She's really good with it. I try to get I have 8 PAs, and I try to have each of them have a little niche
Right.
that they're really expert on.
Right.
Like I have one that's great with Hashimoto's. I've got my gut one. I've got Andy, who's my type 1 diabetic son, who is great with metabolic syndrome and all the new diabetics. So everybody has their own little niche. I also have a psychologist on my team. I have a physical therapist, and I have a nutritionist that knows what they're doing. Most nutritionists I don't agree with.
Oh,
they're-
I understand that. Believe me, and I share your sentiments. So, if I may interrupt you, what do you do as far as getting folks, or how do you try to get folks or keep folks engaged as far as strength training, as an example?
Well, our physical therapist is really into it. And actually, our nutritionist is actually a certified trainer as well. But I'm like you. I like to, and we have a couple guys that, another guys that don't work with me. I refer to them a lot, and they're physical therapists in their mid-30s that are hardcore exercise nuts, power lifters, and they're physical therapists. So they evaluate my patients, and then they put them on a weightlifting regimen. They have everybody pushing the sled. They have everybody. The number one thing they do, teach you how to deadlift. They taught me how to do it. I have a bad back.
Sounds exactly like me.
So they're awesome. They have 90-year-old women. They've got my 90-year-old mother-in-law, 87, actually, not powerlifting, but deadlifting.
I think it's great.
And so those guys are great. So it's almost like a team effort. You ever heard of the Dutch test for hormones?
No.
It's a urinary metabolite test that if you really want to do a deep dive in how your hormones are being metabolized in your body, a Dutch test is a test, but it's very onerous to interpret. So I have somebody that really specializes in looking at that Dutch test. For example, when estrogens metabolize, it goes through either the 2, 4, or 16 pathways.
Yep.
And, so somebody's worried about breast cancer because of strong family history, whatever, and they're worried about it. You go, well, let's get a Dutch test and let's see which pathway you're more prone to.
Sure.
Let's look at all those, what's your cortisol levels? I'm sure you do salivary cortisol levels, but it just takes kind of a deep dive into metabolism of your hormones. But man, it would take you, unless you're really used to looking at those results, it'd take you 3 hours to kind of interpret one test.
Right.
So, you kind of like to. The other great thing I do in my office, Brett, everybody that comes in there gets a Cleveland heart panel. And I design, it's Quest Labs.
Yep.
I don't know what lab you use, but I use Quest. LabCorp and Quest are the two best in the world. But I run this thing called a Cleveland heart panel. And I'll send you a copy of what I check on it, because it's all the hormones and the inflammatory markers, the vitamins, the MTHFR, the ApoE.
Yep.
I do all the, the important stuff that I think, free and total, estradiol levels in men and women. But it's a great test. It's covered by insurance, for the most part.
Interesting. Yes, we've made our own battery up, but I'm sure it's not as comprehensive. It's extensive, but it may not have. I'd be curious to see what's in yours.
I'll send it to you, and you can look at it. And you may have stuff that you check that I need to be checking, but it's a good place for a patient to start with me. And then I always get, I get a CT calcium and I get a carotid IMT to look at their vascular health. You're only as healthy as your arteries, really.
You're only as old as your arteries. Yep.
Yeah.
I say the same thing.
I look at that a lot. But as a matter of fact, I'm going to repeat my IMT here pretty soon. I don't know what you think about that carotid IMT test compared to what you do, but
so what we do here in the clinic is every single person every single year that comes through here. I have an ultrasonographer here. They get an echo, they get a thyroid screen, and the reason why we started doing thyroids is because it's in the carotid window. Yeah. So we started having them look at thyroids, and we have caught thyroid cancers that are occult, and we've sent multiple people for thyroidectomies. So I would recommend grabbing onto an ultrasonographer if you can, and start having them echo everybody: carotids, thyroid, abdominal aorta, femoral. Every single person gets it.
And an echocardiogram.
You got it. And now it's a little tricky to get a hold of somebody. It may not be up in Tennessee. I don't know. Down here, it's a little bit tricky to find somebody who is vascular and cardiac certified. Yeah, but if you dig around enough, you can find them. And I'll tell you, there are very, very inexpensive ways to do it. Very inexpensive. They even have ones where you would get one of your mid-levels to wand over the heart, and somebody is remotely guiding them and say, turn the transducer a little bit to the left, angle it this way. And they are actually doing the echo remotely. So you don't even need anybody on site. Oh, and by the way, I've seen the software myself. I fiddled with it. That software runs on your iPhone. Really? Literally. Yep. I can't remember the name of it, or I should say on your iPad. So there's a little device that goes into your, whatever, USB-C or whatever it is. Okay. Comes out. It's an ultrasound probe, iPad. You link up remotely with the ultrasonographer, and they'll tell you, okay, go here, look here, angle it this way, and they're going to give you the interpretation. Yeah, it's incredible. What we do, we don't use that. I've seen it. I fiddled with it because, of course, they were in the office when they found out that I do ultrasonography here. But we have it's outsourced. The ultrasonographer comes in. She brings her laptop, which, by the way, there are no big clunky echocardiograms. No. Yeah. It's done on your laptop. So, they bring a laptop in that literally is the size of this little surface right here. They've got an ultrasound probe attached to it, and I don't even get it formally interpreted. All I do is I say, guys, give me your interpretation of this. Yeah, the IMT is X thick, or he's got some plaque, or there's some regurg, or they give me a very, very gross. And if there is something that in other words, I'm concerned enough about, off to the cardiologist, or I send a lot of people for evaluations of thyroid nodules, the ENTs. We've caught occult thyroid cancers, all sorts of stuff.
That
So,
is awesome. I need to up my game. And talking to you, I need to up my game in a couple areas. One is my vascular screenings. I do a
yeah,
lot of CT calciums. Everybody gets one of those.
sure.
But I really need to up my game there. And I do the carotid IMTs, but I need to get the echo and the
Yeah,
abdominal
yeah.
ultrasound. I need to up my game with the weightlifting stuff and the evaluations of basic fitness. And I have the capability to do that. I just need to up my game and get one of those in-body scales
Oh,
and things
you'll
like
you'll
that.
love it, and when you see how much information and how much, sort of you can use, because I mean, you're a nutritionist, how do they base as an example, what do they do as far as, they come up with a program for somebody based on what?
Well, basically just experience and looking at somebody. I mean, they'll test your basic fitness, but hey, I mean, they do calipers. We have impedance scale, but
Mhm.
it's not anything like you're doing.
You will be amazed at how much you can do with just this information on this little machine that sits in the corner somewhere.
Oh,
I'm
I'm
telling you.
going to
I
do
mean,
that.
you will be amazed, and if you can find some ultrasonographers, yeah, I think that would add. I mean, your practice seems like it's very, very robust,
We
but I
have a
think that these would be
lot of
very
patients. Yeah.
nice additions,
Yeah,
for you.
very. I'm
I
so
mean,
glad I'm
I mean,
talking to you. I know I'm taking a lot of your time.
no,
Can we
this is
talk
great.
just a minute about back pain?
Okay.
All
So
right.
here's one of my, and I have a million like you. You're only as old as your arteries. That's not ours. I mean, we stole that from I don't know if that was DeBakey who said that. It may have been DeBakey. Anyway, or some wartime a
Yep.
surgeon or something like
Yep.
that. But
DeBakey
anyway,
gave my dad his oral surgery boards. That
oh, is
was his
that
deal.
right?
Yeah, that was before DeBakey was DeBakey, but he
Right.
actually passed my dad
Well,
his
that's
oral
awesome.
surgery board down.
Yeah, that
Him
is
and
awesome.
Cooley didn't get along very well, but anyway, it's
Right.
another story. But
That is
but
awesome.
but
But
anyway, so tell me here's Brett, Dr. Osborn. I want to ask you some things about back. I suffer from back pain. If it weren't for my low back, I'd literally feel like I was about 30 years old.
yeah,
But when I got in my mid 60s, I started getting stiffness in my back. I got an X-ray. I've got extreme scoliosis, which
okay.
I don't know how I got. I guess